Good afternoon and welcome to Ask the Doctor Live. I'm Dr. John Lindberg. I'm the Medical Director of Physical Medicine Rehabilitation here at Emanate Health. And today's talk is actually put on by the Acute Rehab unit at Queen of the Valley Hospital. We did this program every year for several years before the pandemic. It was called Restore. We used to do it at Queen of the Valley. Since the pandemic, we couldn't do it live, so we are now coming to you Facebook Live. And the topic today is The Mind Matters. It's a discussion on brain injury and stroke. It's about a 20-minute talk. If you have questions, certainly enter them in the comment section, and I'll answer those at the very end. This is an organization of the talk today. We're going to go to The Mind Matters, the title of the talk, a little brief on that. Brain recovery, just how does the brain recover after any type of brain injury? Then specific to traumatic brain injury and stroke, we're going to talk about some facts and some brief, like why do we get those? But the big focus of today is it takes a team, the multidisciplinary approach of rehabilitation for these complex disorders, and brain injury and stroke probably represent some of the most complex disorders we get in rehabilitation. And then talk about the rehab unit and why it's important to the course of care. And I think that's a big part of this talk. And again, it takes a team is a big theme to that. And at the very end, we're going to talk about emergency preparedness. And that really is, we haven't talked about that before in Restore. It's something commonly left out. People with disabilities have unique issues with emergency preparedness. And so we're going to add a little bit to the end of that to give you some tips. But first off, to the mind matters. Why I lead with that is that with brain injury and stroke, the mind matters. The brain is extremely complex, and that's what makes brain injury and stroke rehabilitation so complex, is because the brain itself is extremely complex. This is a quote that I have used before once, and I think it's just extremely appropriate to this talk. This is a professor. He's a theoretical physicist out of New York. And this is his quote. The human brain has 100 billion neurons. Each neuron, which is a nerve cell, is connected to 10,000 other neurons. So sitting on your shoulders, everyone who's watching, is the most complicated object in the known universe. And if you can imagine that gets injured, the complexity that ensues and the care that's needed is extremely complex. This quote about traumatic brain injury and stroke even magnifies that. This is a quote saying brain injury is the most complicated disease of the most complex organ of the body. And so again, this talk is going to really emphasize that complexity, but why we need a team to manage this. But first off, a little preface. How does the brain recover? You get injured traumatically through a stroke. We have these three basic phases. It's sort of general. Restoration is what we all think, those first 6 months, where the nerves start to come back online. They might have been temporarily knocked off. In those first 6 months, you start to get that rapid improvement, and that's that restoration. Recruitment is a little bit different. That's where we have duplicity in the brain. There's redundancy. So basically, if one area can't work, we're going to try to get that other to work and sort of take over for it, and that's what rehab is really about as well. Retraining, I want to talk a little bit more about this. This is that learning-dependent neuroplasticity. This is what lasts a lifetime, which is extremely important for brain injury patients to know. Stroke, traumatic brain injury, is that you can improve over a lifetime because of this neuroplasticity. Because neuroplasticity is where the brain, even though we're born with 100 billion neurons, and that's pretty much what we have when we die. We don't grow a lot of neurons, but the dynamic aspect is this neuroplasticity. It's the connections between the neurons. We can either decrease connections or we can increase connections based off what input we give to the brain. We're going to take advantage of that with rehabilitation. And a good example of this that I give to people is that, let's say you decide to take the piano. You start taking lessons, you practice every day, and you're using your hands every day, fine motor skills, very articulate. What's going to happen is your brain's going to take that input and it's going to build synapses in those areas because you're telling the brain the hands are important. You really need them. It's going to grow neurons. Let's say you decided you didn't use your right arm for a year. The brain's going to say, gosh, I don't need these neurons to be connected. We're going to prune these back. So what rehab's going to do, and what you can do over a lifetime, if you have something that you're going to improve upon, or let's say a dysfunction or disability, you can constantly try to kick in this neuroplasticity well beyond when physical therapy ends to keep improving. And rehab's going to focus on that as well. So you have these three general phases. My statement would be rehab goes a lifetime. If you get injured traumatically, stroke, think of this as a lifelong journey for you to maximize your quality of life, minimize dysfunction, and get yourself out in the world. I'm going to go in now to traumatic brain injury and stroke, talk to you a little bit, a couple facts, and then of how they occur, some facts, and then get a little bit more into the team approach. Traumatic brain injury, these are some facts. The majority are falls. That is by far the majority of traumatic brain injuries. Subdural hematomas, you hit your head, you have bleeding in the brain. Motor vehicle accidents is a common one. As you can see, firearms and motor vehicle accidents are the greatest cause of death. Approximately 2 million Americans have recorded traumatic brain injury, and that is very that number is very low because most traumatic brain injuries, certainly those mild ones, the concussions, they never get reported. You can have a lot of problems with a mild brain injury that can last several months. You can have chronic headaches, decreased concentration, decreased memory, but those never get reported. So that 2 million number is extremely low. It's much more than double that of what occurs in the United States. In traumatic brain injury, obviously by the name traumatic, it's a direct trauma to the brain, but what that causes is several sequelae. You can get hemorrhage, you can get bleeding in the brain like that fall, that hematoma. You can get hemorrhage within the brain itself. You can get bruising of the brain. That brain can rub up against rigid bone and get bruised. It can have shear force. The brain's fairly soft. It's in a rigid skull. If you get hit on the head, that brain shakes. These little nerves get stretched, and that actually commonly causes loss of consciousness. Lack of oxygen, drop in blood pressure. If you're in a traumatic event, both of those clearly are a possibility, and both of those will injure the brain. Since the oxygen exquisitely needs, or the brain exquisitely needs oxygen, you have to have oxygen. That's why drowning, if you're underwater for so many minutes, you're going to have permanent damage. Now, the brain has amazing ability to try to maximize oxygen, regulate blood pressure, but only to a point. So you can get brain injury if it really drops low, lack of oxygen, lack of circulation for a prolonged period of time. As far as stroke facts, going into that, each year, 795,000 suffer from a stroke, and that's a rough number. One occurs about every 40 seconds in the U.S. The third leading cause of death, though that death rate is going down. We have a stroke center here, Comprehensive Stroke Center. That with the BFAST acronym that is out there, we really seen a dramatic decrease in mortality as well as long-term disability. That being said, it's still a leading cause of long-term disability, and hence rehabilitation is still required, and still it's an extremely complex rehabilitation process. It is primarily a disease process of people over 65, but certainly we see many younger, hence 25% are under the age of 75 or 65. As far as mechanism of stroke, atherosclerosis, that fatty plaque that builds up on the walls is a big underlying process here. But then you get thrombosis, you get blood clots. That will seal off that artery. We get lack of oxygen. You can have embolus where there's a blood clot that actually will travel down and block an artery. Again, that lack of oxygen will cause that local stroke. Hemorrhage, though, is where you actually have bleeding into the brain. A common reason is hypertension. Maybe you don't know you have high blood pressure. Maybe you haven't been taking your medications. It gets really high. You can't feel it when it gets high until you have an event like this. And vasospasm is out there as well, where a blood vessel will just clamp down. And again, focus, lack of oxygen, local area, and you get a local phenomena where you have brain damage to a local area that will give you a presentation depending on where it is in the brain. So here we have the most complex organ in the body. We actually have damage via traumatic or stroke in these two incidences, but the complexity doesn't stop there. The thing with traumatic brain injury, stroke, is it affects the entire body. It can affect your heart, your lungs, your blood pressure can be more labile. Your pulse can drop, it can get really high. You can have low oxygen, you don't expand your lungs. You can aspirate food, you can get pneumonia. You can have skin breakdown, et cetera, et cetera. So the thing with brain injury is, again, you have that neurological damage. It's the most complex organ in the body with a very complex presentation for medical personnel. But then it can affect the entire body from head to toe. So this is just the emphasis of how or why it's so important to create a team around you. It's just not one event. This is a very complex, very multivariable disease process, and you need to maximize function, quality of life, minimize medical complications. So we want to create that team. And this gets me to the acute rehab unit, which we have at Queen of the Valley Hospital on the 4th floor. This is our mission statement. I'll start off with that: to improve health, function, and quality of life, providing outstanding patient care services in a safe, compassionate environment. If you see function and quality of life are in there, and that's really what we're all about. Certainly we want people medically stable, neurologically maximized, but we want function and quality of life. That's the heavy emphasis: independence. Do the things you want to do in life after an event, and we're heavily emphasizing that. Our unit is a 12-bed unit. It's on Queen of the Valley. It's in the Queen of the Valley Hospital. It's on the 4th floor. We've been there since 1984. I've been the medical director there since 1993, and it's just been a great experience. We have amazing staff there, just caring. It's a very family environment, and the patients pick up on that. It is CARF certified, Commission of Accreditation of Rehab Facilities. That's really the highest certification for any rehab facility in America. And we even have specialties in stroke and brain injury on top of the general accreditation. But this is where it takes a team. So you get onto the rehab unit, you've had a stroke, you've had traumatic brain injury, and here's your team. You could have more than 10 team members easy on your case, all focusing on different aspects. We have me as medical director, we have administrative directors, but we have rehab trained nurses, PT, occupational therapy, speech therapy, social services dedicated to the unit, CNPs, we have case management, again, dedicated to the rehab unit. Plus, we're an acute care hospital. We have other consulting physicians, dialysis, wound care, respiratory therapy, lab, radiology, all of it integrated, because every person who comes, again, very complex disease process, we modify it based off what your needs are. We plug those in, but the key is then you integrate those. You don't want people working in silos. You want everyone working together, everyone communicating. So what we do is Rehab Focus, we integrate on these functional areas. And you could take the top one, cognition and communication. You might imagine speech therapy is really the leader in that. They're going to focus on how to maximize cognition, communication, how to create a program to pull the most out of that person, but they're not going to stop there. They're going to communicate their techniques to the physical therapist, to the nurse, to the occupational therapist. So everyone is working together using the same strategies, because what you'll learn in rehabilitation is what you're doing is repetition. You're repeating good habits. That's how the brain learns. That's how they're creating new synapses, right? So we want the speech therapist to make sure the physical therapist, the occupational therapist are all communicating in the same way. Mobility, same thing. Let's take walking. Physical therapy might lead the way, but they're going to show the occupational therapist how the best way to walk that person from the bed to the bathroom, and to make sure it's the same technique. Use the brace, what equipment to use, technique to use, safety issues, verbal cues, etc. So everyone's on the same page, and you're going to maximize functional recovery and certainly long-term quality of life. All the while doing this, we're maximizing medical stability. We have the doctors on the case, whether it's heart, lung, kidneys, managing any infection, bowel and bladder. Those are being optimized because the brain needs that to maximize that healing in that restorative phase. And then we're taking that person with these functional goals, maximizing them through integration, through repeating in a team atmosphere, good techniques. And that's the key to really rehabilitation for any complex disease process, and traumatic brain injury and stroke being two of the most complex. As far as the end, we are going to end with emergency preparedness. Again, we have not talked about this before. Emergency preparedness for disabled individuals is a little bit more challenging. You can see in the top right, durable medical equipment. Do you need a walker? Do you need an extra wheelchair? Do you have it available in case of an earthquake? Do you have extra medication? Do you have ways to contact family? Do you have an evacuation route? You might need a ramp. If that's not blocked, how else do you get out? Certainly water, food, emergency kits that are accessible because you're disabled. So you have to make sure it's not just emergency kit, but one that you can use. There's certain complexities to emergency preparedness, and we really want to make sure that's part of the rehab program throughout the continuum, certainly on the rehab unit as they leave, so they have an understanding of this aspect. And there's websites, there's apps on your phone, if they're able to use a smartphone, that we can educate them to keep getting more information even after they leave. So this isn't neglected, that this is a part of rehab program of preparedness in case of emergency. It's just really part of just taking the person as a whole and making sure you're not missing out on one area. And that's the talk today. I know this was a very brief sort of introduction to brain injury and stroke, and really wanted to emphasize the complexity of the human brain, why these are complex disorders. We're creating a team, multiple physicians, multiple therapists, rehab trained nurses, etc., to really, in the end result, maximize function, maximize quality of life, which is, again, in our mission statement. And to really do it well, you need a team. You need a team you trust, that you believe in, that motivates you. In our acute rehab unit on the 4th floor, Queen of the Valley, we just had tremendous success. We have great people, well-trained, certainly a family environment to help anyone. If you do have a stroke or brain injury, certainly feel free to call us. This is the number. Ask questions. If you need us, we're certainly there to help you out. And thank you very much. And we'll leave this now for questions. If you have any questions, I'll pick them up and we can answer them now at this time, if you've left some comments. Okay, this is a good one. So the first question we have, does drinking alcohol affect brain function? It certainly does. Alcohol is a depressant. So certainly long-term, high-use alcohol can cause brain atrophy. Certainly like the cerebellum might be exquisitely sensitive to that toxicity. But after an event, brain injury, stroke, we always advise you don't want to have any medication, alcohol that suppresses brain recovery. And certainly alcohol is a suppressant. So we really recommend highly that no alcohol after a stroke or brain injury. Next question, can reading or learning an instrument help an injured brain in long-term recovery? God, that is a great question. It really is. It's a very unique strategy too, because let's say the key thing is you want to improve through repetition good habits. But let's say you tie that into something someone really enjoys doing. They're going to want to do that. And if it's an instrument or music or reading, they enjoy doing that. And the therapist can integrate that into the deficits they're trying to improve upon. You're going to want to repeat that. Let's say, again, could be trying to learn the piano. And let's say you have a weak hand that doesn't have good fine motor skills. Start learning the piano and start doing that. It's going to be extremely hard, extremely frustrating to begin with, but you like the piano, repetition is what's helping. That's a great way to tie in hobbies, interests into your program so you actually participate, you get involved in it, and you'll even get faster recovery. Great question. How can I prevent having a stroke? Strokes are multidimensional. There's a lot of variables, but clearly there's some big ones. Just smoking alone, if you just stop smoking, you've eliminated one that's so easy to eliminate that has dramatic effect in decreasing risk of stroke. Certainly diabetic control, keeping that hemoglobin A1C in check, making sure you're seeing your doctor, you're taking your medications, checking your sugar. That's a big one. Blood pressure is a huge one, making sure that blood pressure is well controlled in a safe range, you're taking your medication. If you get off your medication and you have high blood pressure, especially if it's over a long period, it can cause, accelerated atherosclerosis, more risk of stroke. If it gets really high, then you get the hemorrhagic stroke. You have those. And there is a family history component. If you do have a familial history, nothing you can do about it, but what you can do is maximize these other variables. Talk about diet. Diet's a big one. High cholesterol. Making sure you're getting those numbers down. If you need Lipitor, if you need a medication to ramp those down. So let's say you even have a familial history. You're at a higher risk category. You can't do anything about that. You can really attack all these variables and still really minimize your risk of having a stroke. So a lot of variables, a lot of things you can participate in. Certainly just stop smoking would be a big one if you are smoking. Is acute rehab an inpatient only service? Good question too. Rehabilitation is a spectrum. It's a continuum. Rehabilitation actually starts day one after a stroke up on our neuroscience unit, our comprehensive stroke center. The acute rehab unit is a common phase right after that. It is an inpatient unit. It's designated such. So you spend the night, you're in a room. But you only stay there maybe for a few weeks. After that, you'll go to home health. You'll go to outpatient therapy. There's a variety of other rehab options. They're not considered acute rehab, but they're equally important to really making sure the gains made early are continued. So acute rehab is only inpatient, but remember, it's a spectrum. You have therapy in the home, you have therapy as outpatient, all equally important. How much time do patients usually spend in acute rehab? The acute rehab unit on the 4th floor, an average length of stay is about 2 weeks. It can be as little as 1 week. It can maybe go up to 3 weeks. It really is variable based off the patient's needs. It is not a long-term location. You don't go to a rehab unit and stay several weeks, going on months. That's not its designed. It's a lot more of an intensive 3 hours of therapy day, multidisciplinary, rehab-trained nurses, doctors every day are seeing you to really accelerate that recovery, make sure you're medically stable, to get you into that next phase, home health, outpatient, or common. There are skilled nursing facilities that sometimes are needed afterwards, where you still get daily treatment. It's just not as aggressive, maybe not as much per day. Physician involvement is less, but that's even an option too. But acute rehab, that's roughly 2 weeks. And again, you're getting 3 hours of therapy a day. How much time do patients usually, okay, I just questioned that. When my brother swallows, his drink or food gets lodged in his windpipe and sits there. It eventually comes out. Can this be corrected by therapy? Absolutely. Yeah, that's actually extremely important to deal with. Speech therapy is the most important therapist for swallowing, and there's a variety of reasons that could be happening. And you might even need to get an ears, nose, throat physician involved, gastroenterologist involved with that specific situation. But the key thing with that issue is risk of aspiration, risk of pneumonia, which then of course puts you in the hospital. You can get septic. You can end up on a ventilator. So what we need to do is approach an issue like that early. If it's happening at home, you get into an outpatient speech therapist. They can do studies like a video swallow study, which is an x-ray, or they can even check where the food's going. If it's hanging up there, where is it hanging up? They can do what's called a FEAST, fiber optic study, where they can even put a little cannula down your nose and take a look at the food live. There's such advanced techniques in swallow improvement. And on top of that, not just diagnose the problem, but then there are exercises to improve it. Equally important to get that person so they can swallow safely, minimize risk of pneumonia, make sure they hydrate, they get a sufficient calories. So that's extremely important. Get into a speech therapist if you're at home. Get a referral to an outpatient speech therapist. If you're in a hospital, make sure a speech therapist certainly is on the case and ask your doctor for that. Okay, next question. How can I mitigate risk of falling in my home or outside? I saw this as a leading cause of brain injury. Like on acute rehab, we do what's called a home evaluation, and you can almost do one at home. Falls are really checking the layout, extension cords, throw mats. Do you have the appropriate ambulatory assisted device? Do you need a walker instead of a cane? So you can really take the lay of the land. Stairs, very common risk. Uneven surfaces, one step without rails. Your house has a lot of potential risk factors. A therapist can actually, if you have a home health therapist, they can really review that with you. If you're in the hospital, we can do what's called a home evaluation, or you can even just describe your house to a therapist if you're in the hospital, and they can give you guidance. But also making sure your walking is safe based off a therapist. You have the right assisted device, you're walking the right distances. If you over fatigue, legs get weak, you can fall. Balance is a big problem. As we get older, just aging alone can decrease your balance. There are exercises, though, to improve that, just like you can improve a muscle through repetitive strengthening, doing curls for your biceps. You could do the same for balance. You can improve balance by pushing that person in a balance program, giving them exercises that are safe so that they don't induce a fall, but can push the limit so that your balance actually improves. So getting into a physical therapy program, if you notice balance programs as an outpatient, they can set you on a good program too. So a lot of things you can do to mitigate, but look at your home, see where the risks are. Can you share any technology or equipment that are available to enhance rehab therapy for patients? There's tremendous. The technology is just booming. You can go, there's a lot of interactive technology out there. We talk like in speech therapy, you have fiber optic swallow studies. Physical therapy, there's orthosis or braces that are more dynamic, that can be controlled through neuromuscular stimulation. There are interactions with cognition that give feedback into almost like an interactive computer program. Software is booming. There's going to be virtual reality, augmented reality will have a big say. The technology for rehab continues to grow exponentially and will continue to be integrated. And that's why, again, if you get into a team, it's a complex disorder, a lot of variables. You want to tap into that technology that you can use acutely, but even as an outpatient, even after maybe you're done with physical therapy or doing your home program, you might want to even keep in touch and make sure, is there a new technology out there that you can even integrate back in, get back into PT and put that as a part of the program. But technology, all three therapy disciplines, rehab, nursing, tremendous amount of technology, and it's still growing. What are the signs and symptoms of a stroke? What should I do if I see someone having a stroke? We have the acronym BFAST. If you, you'll see that posted here in the hospital. B for balance, E for eye or vision, F for facial weakness, A for arm, like you might have drift, clumsiness of the arm, S for speech, maybe some slurred speech. But T is the key thing, is time. What do? You call 911. Stroke now is like a heart attack. And that's been the revelation of stroke as far as the acute care, is you treat it like a heart attack. You call 911, you use that BFAST acronym, you see anyone having it, you need to get to that emergency department fast. They'll have a telehealth neurologist working with emergency room physician. You have neurointerventionalists on call 24/7. So within 24 hours, it's almost like a NASCAR pit stop. You're going through from A to Z, and they're making sure they're intervening fast, but you have to get there quick. That T is really important with that B fast. So pick up on symptoms. It's a little bit different than heart attack. I understand. Heart attack, chest pressure, chest pain, radiates to the arm, to the jaw. A little bit more precise, even though that can vary a little bit. Stroke is a lot more variable. It could be just blurred vision, a little double vision. Your face droops just a little bit, a little slurred speech. Maybe you're on the phone with your family member and it's hard to say words all of a sudden. It's subtle, and you might just say, look, maybe I'm just tired, but you can't do that anymore because there's just too much technology. And here we are with the Comprehensive Stroke Center, and we see it every day. If you can get to us fast, you don't have any sequelae. You never need to see me. And that happens a lot. You're seeing a lot of people who have initial stroke symptoms with these interventions, thrombectomies, TPA. They come out basically back to their old self without ever even needing me. So again, picking up on these symptoms is important. Treat it like a heart attack. You're calling 911, getting to a Comprehensive Stroke Center, which we have here at Queen of the Valley Hospital. Does breathing exercises and medication help with brain function? Anything that optimizes oxygen. Certainly, let's say you have pulmonary disease. You want to make sure you have proper oxygenation, even with exertion. And that's where breathing techniques help, because as you exercise, your oxygen levels can go down. But let's say you have emphysema or COPD, there are certain breathing strategies that you can use to make sure you keep that oxygen level up and make sure you're optimizing brain recovery. Because again, the brain's exquisitely sensitive to oxygen levels. If you can keep that up, we want that in the 90% range, you can maximize recovery. So breathing exercises, very important. The last part of that question, and meditation. And as far as meditation, the one thing I see, meditation I think is actually an excellent part of anyone with a brain injury when you get to a certain level. And if it's for you, for some people meditation's not, but meditation can really just put your mind at ease, decrease that anxiety, that overload of the future, and can really ground you. And I think a lot of our patients after brain injury and stroke have a lot of anxiety about the future. Will they get back to their old self, get back to their old job, drive again, go back to the golf course, whatever that may be. And meditation can really be a great way, rather than going to medications and trying to get medication from a physician for anxiety. Meditation would be an extremely good way to do it and to find ways to integrate that into your program after you go home. Good question. Those are all very good questions, and I think that is our last one, actually. But thank you again for tuning in to Ask the Doctor Live. Again, I'm Dr. John Lindberg. This is Acute Rehab Unit presentation. It's our yearly restore. We do this on National Rehab Awareness Week, which was last week, but this is the month. And really appreciate you tuning in. Questions after this, I gave you the number to the rehab unit. Certainly feel free to call. We have great staff, all with great knowledge, and I'm sure we can answer your questions. Thank you very much for tuning in.
If you like this video, please give it a thumbs up to help more people find this important health information. Click the subscribe button and the notification bell for access and reminders to more Emanate Health videos. We upload informative video content every week.